Hello, everyone. My name is Amanda Owen, and I am one of the EMS training officers here at Global Crashers Rescue Squad. Today, we are going to be going over obstetrical and gynecological emergencies. So, one reason why I really like this topic is because if everything goes right, this is one of the few times in EMS and in what we do that we get to be a part of something happy. Most of the time, whenever we are responding to a call or anything of that nature, it's generally because somebody's having the worst day of their life. Now, granted, having a baby delivered by EMS is probably not what was on their to do list or in their birthing plan, but sometimes it happens, and it can be a very joyous occasion when everything goes correctly. However, sometimes things don't go correctly, and that is one of the big things that worries us as providers and as responders. So here are a few topics that we are going to be covering today. We're going to be covering the anatomy and physiology, physiological changes during pregnancy, all those body changes that women go through during the pregnancy and slightly afterwards, the labor and delivery of the baby, how to perform your patient assessments, what a normal childbirth is like, um, assessing the neonate and dealing with issues with that little neonate, care after delivery. We're going to go over some childbirth complications and some gynecological emergencies. So, first and foremost, review of the anatomy and physiology. So, in the external genitalia, so on the outside of the body, you have the labia, the perineum, and the mons pubis. The internal genitalia, the internal anatomy. So, we have the vagina, which is the birth canal, it is a smooth muscle. The ovaries and the fallopian tubes. The ovaries, that's what is responsible for producing that egg or that ovum. The fallopian tubes are where the fertilization generally occurs, not always. And an ectopic pregnancy occurs outside of the fallopian tubes and then implants somewhere outside of the uterus. So the uterus is that muscular organ. Kind of looks like an upside down pear, but we'll see a picture here in just a minute. But it's hollow. Um, it's located midline of the woman. So if you have midline, it's straight down. So it's going to be midline in her abdomen. And it is the very bottom of the abdomen. A lot of times people don't realize exactly how low the uterus is in the body. Excuse me. That is where the fertilized egg should implant and develop into a fetus, a baby. Um, so it stretches and it grows as the baby grows. So that is an amazing feat of women in their self. Then you have the cervix, and that is the muscular ring that separates the uterus from the vagina. So the cervix is what keeps the umbilical sac and the baby inside the uterus as opposed to dropping down into the birth canal. So the baby's not just going to fall out without that cervix opening. So here's a picture, a diagram. For those of you watching online, kind of hard to see. I'm sorry, I can't do anything about the glare. But you have the ovary here, and then you have the fallopian tube that comes into the uterine cavity. Here is the cervix, and here's the birth canal or the vagina. A lot of people think that these fallopian tubes are connected to the ovary, but they're actually not. The ovum will actually kind of float in between there. That's the reason some people can actually have abdominal pregnancies. They are not, they have not implanted in the uterus itself. And then up here at the very top of the uterus is the fundus. And we're going to go over that here in just a little bit further about some things that we can do to help the mother after birth with the fundus. All right, so the female reproductive cycle. So menstruation, that is stimulated by estrogen and progesterone. The ovary then releases the ovum. The uterus wall thickens, and the fallopian tubes move the egg out of the ovary, comes out of the ovary, and the fallopian tubes actually move the egg into the uterus. Um, and then, if the egg is not fertilized, then the uterine wall will start to expel. That is when menstruation happens. Bleeding typically lasts 3 to 5 days, depending on the woman. Some women's periods are harder than others. A lot of that can be due to PCOS or endometriosis, all kinds of medical issues that can make these menstruation periods much harder on the female. All right, and then we get into fertilization. That is when the sperm reaches the ovum. And then, once the sperm reaches the ovum and fertilizes the egg, and everything becomes one, then the ovum becomes an embryo. That is that fertilized egg. So then the embryo typically should implant in the uterus, and that is when the fetal stage begins. So let's go over some physiologic changes in pregnancy for the woman. So, changes in the reproductive system. 9 months is a typical pregnancy, 40 weeks. Those are separated into 3-month trimesters. So you have the first trimester, which is the first 3 months. So that's your first 12 weeks. And then you have the second trimester, which is, that goes to your 27, 28 weeks. And then you go into your third trimester, which is the duration of the pregnancy from that point on. So the placenta is an amazing organ that basically has maternal and fetal tissues. It is part of the baby, it's part of the mom. That is where any of the oxygen exchange happens, the nutrients exchange happens between mom and baby. That is how mom feeds baby. That is how certain things can be passed from the mother to the child. And then you have the umbilical cord. And the umbilical cord is what circulates the blood, and it is expelled with delivery of the baby and the placenta. So the umbilical cord is what connects the placenta and the baby. All right, so the amniotic sac. The amniotic sac is the fluid that surrounds the baby. It protects the baby, it cushions the baby, and it maintains that constant fetal temperature that that baby needs. Because they don't have to worry about regulating their body temperatures when they're in mama. Mama's body handles that. The amniotic sac handles that. Mom doesn't have to think about it. Baby doesn't have to think about it. Now, once that baby is born, then that baby has to learn how to regulate their own temperature. That can be very difficult on some babies, especially if they are premature. So if for some reason you are on the scene of a premature delivery, please remember, as with all babies, that you need to keep things very warm, turn the heat all the way up in the back of your truck, emergency blankets, warming blankets, all of that. Cover that baby's head, but especially when it's a preemie baby, because they cannot regulate that temperature. Sometimes they have not done that practice breathing in utero that a full-term baby will do, depending on the gestation of the child. So here's kind of a picture that shows how the baby in the amniotic sac grows throughout the pregnancy. So here we are at 4 weeks. Here we are about halfway through, 22 weeks, 27. And then you can see as the baby gets bigger, mama's organs get pushed upward. And as they get pushed upward, it becomes harder for mama to breathe because your diaphragm's pushed up. Everything's kind of shifted. You got that pressure on your bladder that makes you go pee all the time. The kicks will get you. Sometimes that baby will kick out of nowhere. But as you get further down towards full term and towards that 40-week mark, that baby starts rotating upside down to that head down position, to that birthing position. So some other physiological changes that women go through during pregnancy are They will go through cardiovascular system. Um, those changes there, they have an increase in blood volume, they have an increase in cardiac output, and an increase in heart rate. And a lot of times, if a woman has any heart conditions, those have to be very closely monitored by prenatal care. Um, Respiratory system changes. So they have an increase in oxygen demand and consumption. Plus, it's more difficult for them to breathe because that baby is pushing up. As that baby grows, that diaphragm moves, organs move with it. So it becomes harder to take those big, deep breaths. The gastrointestinal system. So nausea and vomiting is a huge, huge thing for a lot of pregnant mothers, particularly in that first trimester. Now, there are some things that doctors can do to help with that, but those mothers need to be trying to get in as much fluid as they can, because if they have that nausea and vomiting, they are losing a lot of fluid with that. Sometimes eating something while you're still laying in bed, Cheerios, dry crackers, anything of that nature is going to help them with some of that nausea. If they are experiencing severe nausea and vomiting, please try to get them to go see their OBGYN. They may need some fluids. They may have some issues that need to have a little bit further looked at, because there's morning sickness and then there's like extreme morning sickness. And those extreme morning sickness things kind of need to be looked at. They can, while you typically gain weight in pregnancy, some women can actually lose weight in pregnancy because of all of that nausea and vomiting, which is not good for the mother and it's not good for the baby. So anytime you run across a patient like that, please try to get them to go see their OBGYN. They have slow digestion. So things in that area tend to slow down. So you eat something, they become very constipated sometimes. Sometimes they need to reach out to their OBGYN to see if they can find some safe options between the mother's choices and the doctor's choices to try to alleviate some of that constipation. Um, Hormones. So not only are you now pregnant and you have all these hormone fluctuations and everything in your body is changing, your hormones will, some people call it pregnancy brain, all kinds of things. There's all kinds of modern terms that people use to describe what is happening to the mother. Her hormones are all out of whack. It's just one of those things. Also, with the hormones, it can make your ligaments more elastic, so they are more vulnerable to injuries. Falling, and then whenever you fall, sometimes you break bones, things of that nature. More prone to those sprained ankles, things of that nature. So a lot of times we do get called out for a pregnant female who was also injured. So you have to kind of, while you are worried that she's pregnant, you also have to think about, what can I do for the mother? For the mother herself. We are called there because the mother fell. Nothing's happened to the baby. Obviously, things need to be checked out with that baby. But we are there at that time. The mother is our patient. Um, Additional weight affects their posture. Um, so you have a very increased amount of weight on your front end. So they tend to have to lean, or it pulls their body forward in some way. And that can often lead to back pain and balance issues. So we have these ligaments that are more elastic now, and we have balance issues. That is a recipe for disaster for these mothers. So just keep those things in mind. And pre-existing medical conditions. So pre-existing medical conditions such as diabetes, heart problems, things of that nature, respiratory problems, those can become much worse and need to be followed much more closely in these pregnant patients. They need to be getting that prenatal care. It's extremely important for prenatal care in these patients, in all patients. Prenatal care is extremely important. You will hear me harp on prenatal care because a lot of times they can catch things before they happen, or if you're established somewhere, then they will have that good communication with their doctors so that they can figure out things that aren't right and things that need to be checked on throughout the pregnancy. So we're going to talk quickly about supine hypotensive syndrome. So this is when a pregnant woman is laying on her back in that supine position. We all remember from EMT class, supine is back down. They are facing up, and up is in supine. So the placenta, the infant, and the amniotic fluid total will weigh somewhere between 20 and 24 pounds, typically. That is not always, but typically that's 24 pounds of extra weight in that woman's abdomen. Whenever a pregnant woman who is a little bit further along lays on her back, then um, that weight will come down and it compresses the inferior vena cava. That in turn decreases cardiac output, which will cause dizziness, a drop in blood pressure, and a lot of times they will pass out. So that is the reason they say that pregnant women should be laid on their left side, and as opposed to um, supine. So if you have that pregnant woman in the back of your ambulance, whether it's for a pregnancy-related issue or something else, do something so that they do not get this supine hypotensive syndrome. Excuse me. So as we're going with that, let's talk about a little bit of CPR with that. So it can be very difficult to perform CPR, one, on a pregnant woman, because you're looking at 2 lives now as opposed to 1. But you also have to remember that there's nothing that you can do for that baby at that time other than keep blood pumping. So the same thing that's going to help the mom is going to help the baby. But sometimes if you have enough responders, you can have them shift that weight, kind of pull it where it's not directly lying over that vena cava. Try to do that. You're always supposed to be doing CPR on a hard, flat surface. This is one reason why I love things like the Zoll Auto Pulse or things of that nature. Because as that Zoll Auto Pulse is working, you can roll a towel or a blanket and put it under that right side of that patient's on the board, under the board of that patient that she's laying on. And it's not a long spine board, it is the board of the auto pulse. And that can kind of shift the weight off of that inferior vena cava so that CPR can be effective for this patient. And that auto pulse will still keep going. That's just the device that we carry here at Global Captures. But there is things like the Lucas device and things of that nature. Some people have Lucas, some people have auto pulses. Either way, they can be great assets, especially in rural settings, because you may not have a lot of first responders, or it may be in an area where there's not a lot of first responders to help you out, fire departments, rescue squads. But also we have extended transportation times. So for me, myself, to get to a hospital that has a birthing center, I am looking anywhere from 30 to 45, 50 minutes, depending on where I am in my district. So that is a long time to have to try to do CPR. Granted, we do work on scene, except for in extenuating circumstances, and a birth might be one of those, or a pregnant patient, I'm sorry, not a birth, but a pregnant patient may be one of those extenuating circumstances. So the labor and delivery. All right, the first stage of labor starts with regular contractions and ends when the cervix is fully dilated. So whenever we're talking about dilation, that is not something that we check. We are not trained to do that. You don't do it. But that cervix, so that barrier between the uterus and the vagina or the birth canal, it opens up to about the size of a bagel. So if you think about a bagel, that's about 10 centimeters. And you can find all kinds of videos online showing examples as they go around this little wooden board of how wide the cervix opens for childbirth. So it starts when regular contractions. So regular contractions are a big thing because a lot of women will experience Braxton Hicks or false labor. Um, Now they are contractions completely. They are very felt by the mother. However, they tend to be irregular, and they will increase and decrease in severity, but they tend to be very irregular. So make sure that you're counting those contractions. So how you count contractions is you start from the time that the first contraction starts to the time that the second contraction starts. That's how far apart your contractions are. So from start to start. And you also want to measure how long those contractions are. But as with regular contractions, you tend to they are on a timed frame, and that time will get shorter and shorter and shorter as birth is more imminent. So the second stage, is when the baby enters the birth canal. So that's whenever it starts, and it ends when the baby is born, when the baby makes its grand appearance fully. The third stage, that begins after the baby is born and ends when the afterbirth is delivered. So the afterbirth is the placenta. So that amazing organ that goes between mom and baby and is in charge of all the nutrients and the oxygen being taken between from the mother to the baby, that gets expelled after the baby is born. And that needs to be taken to the hospital with you. So put that baby, not put that baby, but put that thing in the placenta in a biohazard bag and take it with you because they need to look at it. They may have to do something with pathology depending on um, if the baby's premature or not. That just depends. But you want to take the placenta with you. They also want to check it and make sure that it has all come out because you don't want a piece of the placenta being stuck in there because that can also lead to sepsis and problems for the mother later. All right, so the first stage of labor, those Braxton Hicks contractions that we already talked about a little bit. So they are irregular, they are not sustained, and they do not indicate impending delivery. The women need these Braxton Hicks because it is actually preparing the body for labor. It is helping move that baby into that good birthing position, putting them head down into the birth canal. Granted, that doesn't always happen. Sometimes babies, they don't want to be head down and they tend to flip around. It's just one of those things. Um, but remember that Braxton Hicks are those irregular contractions. You have lightning. That is the fetus movement from high in the abdomen to low down to the birth canal. Excuse me. So contractions of the uterus produce normal labor pains. Characteristics of labor pains, So you need to know the contraction time that we talked about and the duration. So that contraction time is from the start of the first contraction to the start of the next contraction. The duration is how long that contraction lasts. So you want to know the interval and the frequency. How often is this happening to the mother? When they last from 30 seconds to a minute and are 2 to 3 minutes apart, delivery of that baby may be imminent. So you need to be prepared at that point that you may have to deliver this baby. And then you will have breaking of the amniotic sac. That is what people call the water breaking. My water broke. So sometimes that can be a big gush. That's what you typically see in the movies and on TV. That is not always the case. Sometimes that amniotic fluid can slowly leak out. It can happen both ways. And if you were on scene of somewhere where water has broken and it is still, they haven't cleaned it up, something has happened, or the water breaks on you in the back of the ambulance, take a look at it. That may seem kind of odd, but I want you to take a look at it and see if there is any meconium staining. And meconium staining is where the baby has had a bowel movement in utero, and that can indicate that there may be fetal distress. So that baby is still hanging out in that poopy amniotic fluid. So that can get in their lungs, that can get in their nose, their mouth. So not only do you need to clean this baby very well, but you need to be aware that there may be some airway compromise there, and that the hospital that you are going to needs to know. They need to know ahead of time. You need early call-in reports. You need to let them know what is going on. You need to let them know that they have had amniotic staining in the amniotic fluid, or meconium staining in the fluid. So they can be thinking about antibiotics, if they need respiratory. Is this baby going to have to be intubated? Are you going to have to intubate this baby if you are of that level of care? So just keep those things in mind. But those are things that you definitely need to be looking for and letting the hospital know early. All right, so the second stage, that is full dilation of that cervix. That is when they get that bagel-sized cervix. The contractions are increasing in frequency. They are coming more often. They will often have severe labor pains. And the mother oftentimes feels the urge to push, or feels like she's going to have a bowel movement. Have you ever heard of women that have babies in the toilet? It's because they feel like that they have to poop. They feel like they have to have that bowel movement. And, we're constipated anyway because of all these physiological changes that we have going on. So pushing to have to poop may not be that big of a deal. And there comes baby. So the EMT or provider will have to decide whether to transport the patient or keep her where she is and prepare to assist with the delivery. We do not deliver babies. We assist the mothers deliver the babies. So whenever you're making that decision, whether you are staying and playing or load and go, you need to look, is that delivery imminent? So some things you need to look at is that imminent delivery. How far are you from a birthing center? Are you 5 minutes? If you are, that's great. And you think you can make it and that baby's not crowning yet, cool. However, if you were like me, and if you're lucky, you are 30 minutes from that birthing center, and that baby's head is crowning, you're not making it to that birthing center. You are going to have to deliver that baby on scene. There is nothing that you are going to do to stop it. I always love hearing the jokes from people. Oh, I'll put an aspirin between their knees and tell them that, to keep it there. Don't open your legs. It's not going to work. I put $100 bill between their knees and tell them if they can keep their legs closed till we get there, they can have it. If that baby is coming, that baby is coming, and there is absolutely nothing that you can do about it. That baby, nature is taking over. That baby's doing its thing, and mama's body is doing her thing. So after that wonderful little baby comes into the world, contractions will resume until the placenta is delivered. Now, those may not be as intense. She may not have as much pain, but that placenta will then deliver. That usually happens within 10 to 20 minutes of the baby delivering. Let me go back for just a second. And we will cover this later on, but I want to go ahead and mention it since we're here. So if that placenta has not delivered in that 10 to 20 minutes or soon after, then you're going to have to do that fundal massage. So you remember earlier whenever we were looking at the anatomy and I said that we would talk about the fundus later? Here's one of the times that we're going to do that. So if that placenta is not delivering, then you need to take the palm of your hand and you are going to massage the fundus. And it is lower than you think, and it is not going to feel good to the mother. This can also help with after birth bleeding, because a lot of times hemorrhage is a major, major problem for these mothers. So keep that in mind, and we will be discussing it again later. But since we were here, I wanted to go ahead and discuss that. All right, your patient assessment. So assessing the woman in labor. Assessment is focused on imminent delivery. But here's some things that we need to think about their name. Calling that woman by her name may be one of the most personal things you can do at that point because you are recognizing them as a person, not just them as a laboring mother. When is their expected due date? How old are they? Are they at the point where they are a geriatric pregnancy, where they may have more complications? That is nothing against women who have children after the age of 35. That's just what it's called, a geriatric pregnancy. When was their expected due date? So if they are due in middle of May and they had their baby in March, that's a little bit of a problem. So that baby is now looking at being around 30-ish weeks, depending on the dates there. So if you have a mother laboring who is at 30 weeks, that is a major cause for concern because one, why is that baby coming early? Two, are they able to breathe on their own? Some babies at that point are not. Practice breathing has generally started at that point in utero, but they may not be doing it consistently. Or they may not be able to keep up. They may need supplemental oxygen. Once they get into a NICU, they may need BiPAP or CPAP or something of that nature. Those infants generally need some oxygen to help them out in one way or another. Is this her first pregnancy or has she done this rodeo before? Has the patient seen a doctor about her pregnancy? Some people do not want to see doctors. That is their personal choice. It is not for us to judge. We just need to know if they have had prenatal care. So have things been being watched? If they have not received prenatal care, then they are considered high risk at that point because we don't know what issues could be there. When did the labor pains start? Did it start 5 minutes ago? Did it start 6 hours ago? And you were just riding it out trying to stay at home. Does the patient feel the urge to push or have bowel movement? If that's the case, you need to start getting ready. Get that OB kit. Get it laid out and in the order that makes you happy, where you know where everything is. You have to examine for crowning. Sometimes this can be a little awkward for the provider or the patient or the patient's family. Try to keep as much modesty as possible. Granted, they may not care at that point. Still try to keep their modesty as much as possible. You are going to have to look. That means if they are wearing any clothing that is restricting your visual inspection of the area, it has to be removed. Pants, underwear, whatever else may be there. If they're in a nightgown, that's great. That makes things a whole lot easier. But things of that nature, you need to be able to look to see if the baby is cramming. You can feel for uterine contractions. So you can, when the mother says that she's having contractions, you can feel in her abdomen and you can feel it getting tighter and loosening and things of that nature. You are then also going to take vital signs on this patient. You need to know if she's hypertensive or hypotensive. So hypertensive, there could be some preeclampsia, eclampsia, things of that nature. If they have a history of that or not, it can come on very suddenly. Hypotension, so that can be signs of bleeding. Some patients become more hypotensive during their pregnancy because of that increased blood volume and increased work. Sometimes they just can't quite keep up. So need vital signs. Make sure ABCs, as always, airway, breathing, circulation on all patients. I know we get super excited about pregnancy, you're super anxious, whatever the case may be for you. All right, so we are going to assess the woman in labor. So we're going to be looking for things that might mean that we might need neonatal resuscitation. So no prenatal care, premature delivery, labor induced by trauma. So if they were involved in a car accident or a fall and now they're in labor, those are things that may indicate that we have to resuscitate this neonate. Multiple births, twins, triplets, things of that nature. History of pregnancy problems. So especially if they have been told that they have placenta previa. So placenta previa is where you have the opening of the birth canal. This is where the placenta may partially or fully cover that opening. So placenta previa is something you definitely need to be aware of, because if that placenta is there, baby can't go through. That's just not, and they will have bleeding. Um, Placenta previa, you're not going to have a whole lot of pain with that, but you will have bleeding. Breech presentation, that is where that baby does not want to turn head down. They keep turning right side up. They have to do things in the hospital to help with that. Labor induced by drug use, especially narcotics. So, if you have a mother who is a user of narcotics and things like that, be aware that you may have to Narcan that baby. Be aware that you may have to Narcan that mom. They both get Narcan. Everybody gets Narcan. Meconium staining, whenever the water breaks. So again, that's whenever the baby's had that bowel movement in utero, and you have to be aware that you may need to resuscitate that baby. Normal childbirth. So you need to control the scene. That does not mean that you're the boss of everything. You are not. Mama is. But you need to try to keep people calm and collected. That includes yourself. Because, again, these calls are pretty exciting. There's things going on. A lot of people don't get to deliver babies in the field. So you need to control the scene, make sure things are calm. Give people jobs if you need to. Do we need that boiling water? Nope. Do we need the towels? Maybe. Go send them to do a job. Give them something to do. Collect medications. Just give them something to do. Wear your proper PPE. So, a lot of times proper PPE consists of gloves. And that is great, but amniotic fluid can go far and wide. So, try to wear your eye protection. And if you have the time to put on a gown, I highly recommend it, because you do not want all of those amniotic juices all over you until you get that baby delivered to the hospital and get back, decon your ambulance, and then you get to go shower. So you do not want that on you during all of that. So if you can wear a gown, wear a gown. If you have time to put one on, do it. Place the mother on the bed floor or ambulance stretcher, somewhere where she's going to be comfortable. Remove the clothing that obstructs the vagina. Position an assistant, so whether that is the father, whether that is your partner, another responder, the patient's mother, somebody up there to talk to mom, because somebody needs to be talking to mom as well. And you need to position your OB kit. So you need to have that laid out and ready. And again, these things are exciting, so don't just rip open your bag. I know we want to get open quickly. We don't want to take the time to sit there and carefully open. You need to take the time. Slow is fast, fast is slow. So whenever you rip that bag open, things go flying. And then you have to look for them. And that's not what you want to do. When possible, make the environment as warm as possible. So in the back of that truck, crank that heat up. I don't care if you're sweating. I don't care if you're hot. It ain't about you. It is about mom and baby. So here's just a picture of an OB kit that is laid out. You have your clips, you have your scissors, you have your bulb syringe, you have blankets. I love having a head covering for the baby. I personally have one in my truck. I have a little Ziploc bag that has baby blanket and head covering for the baby in my truck that I personally put in, because nothing's worse than not having something to cover that baby's head. I have done it with a washcloth, things of that nature, covering that baby's head. So off-duty delivery supplies. It can happen. So clean sheets and towels. It says heavy flat twine or shoelaces. So it says new shoelaces. A lot of times people don't have new shoelaces. Don't use your shoelaces, use dad's shoelaces. Take his shoelaces if you have to. Paper towel, plastic bag for the placenta. Clean unused rubber gloves and eye protection, and head covering for the baby. Delivering that baby. You want to be in a position where you can view the vaginal opening. Be prepared for the patient to experience a lot of discomfort. We've all seen it in TV shows or in real life. Mama's hurt. Provide emotional support to her. That's the reason if you can have somebody up there to help her and talk her through things and be there with her and call her by her first name if she's okay with that, that's what you need to do. Communicate with the patient through the contractions, through everything that's going on. Talk to them. So assisting with a normal delivery. Keep someone at the mother's head. Position a hand glove over the vaginal opening when the baby's head starts to appear. So whenever you place that hand there as the head bulges, it's to prevent a sudden, uncontrollable, explosive birth. Place one hand below the baby's head as it delivers. So if the amniotic sac has been broken, at this time, you can use your fingers to puncture a hole in the membrane. Once the head delivers, check to see if the amniotic cord is wrapped around the baby's neck. So feel there and make sure. If it is around the baby's neck, try to work it around the infant's head if you can. If not, then you're going to have to cut it. Make sure you are cutting an umbilical cord and not the baby. Once the head delivers, yep. And then you're going to help deliver the shoulders. Support the baby's head during the entire process, the baby's head and the body. Assess the airway. Use a syringe or a bulb check, or not a bulb check, but a bulb syringe, bulb suction to suction the nose and the mouth. So we're going to suction the mouth first because they are nose breathers. So you're going to suction the mouth, get all of that fluid out. Then you're going to do one nostril and then the other. Note the time of birth. I love being able to tell a responder, tell dispatch, we now have 2 patients, or tell dispatch, no time of birth. So the neonate. You have to assess that baby as soon as they are born. You're going to stimulate that baby. How do you stimulate that baby? Is you clean them off. So babies come out, they are wet and slippery. You are going to dry them off so they are no longer wet and slippery. Wet is going to have them have a hard time controlling their body temperature. And slippery, you don't want them falling or being dropped. So, and as you are drying that baby, you are stimulating them. Protocol usually calls for noting ease of breathing, heart rate, crying, movement, and skin color. That's your APGAR score. So your APGAR does not guide resuscitation efforts. It is based on appearance, pulse, grimace, activity, and respiratory effort. Everybody should remember that from EMT school. There's how that is scored. So a baby can get a total of 10 points. So keep that baby warm. Heat retention is high priority. We talked about drying the baby. Discard those wet blankets and towels. Wrap the baby in dry blankets and towels. Infant swaddler or space blanket if you have it. Cover the head and encourage both mom and baby. When you cut the umbilical cord, circumstances necessary for cutting the cord. If it is wrapped around the baby's neck, it cannot be slipped over the head. If the attachment impedes resuscitation efforts, if that baby needs resuscitation and you cannot do it for the umbilical cord, you cut it. If attachment interferes with urgent need for transport of mother and baby, you cut it. If protocol requires it, you cut it. Guess what? North Carolina protocol, you cut it. So as you are cutting this umbilical cord, you are going to be keeping that baby warm. You're going to use those sterile clips to put on the umbilical cord. You are going to place one clip about 10 inches from the baby and another clip about 7 inches from the baby. And you're going to cut in between, 7-10 split. When you are cutting an umbilical cord, it is much thicker than what you might think. They're pretty tough. So cutting that umbilical cord can be tougher than you think. So you are going to cut that umbilical cord when the cord is no longer pulsing. That is whenever you are able to do that. Carefully move the baby so no trauma is brought to the clamped cord. Place the baby on the mother's abdomen after the birth process. Abdomen, chest, you want that skin to skin if mother is comfortable with that and if mother is willing to do that. Benefits of skin to skin. It decreases stress on both mother and baby. It promotes bonding. Let them breastfeed if they want to breastfeed. If baby's trying, Let mama and baby try. Stabilizing the baby's body temperature, heart rate, and oxygen levels. It produces a stronger milk supply for breastfeeding moms, and it reduces postpartum bleeding in moms. So even that breastfeeding will reduce postpartum bleeding in moms. So neonatal resuscitation, provide warmth, assess the body's airway, establish that the baby is breathing, evaluate respirations, heart rate, and muscle tone. If shallow, slow, gasping, or absent breaths, provide positive pressure ventilations to a rate of 40 to 60. So whenever that you are breathing with those little neonate BVMs, remember that you're just doing enough to see chest rise. Just little puffs, just enough to see that chest rise. Their heart rate, if it is less than 100, as we all know from CPR and ACLS, provide artificial ventilations. If it is less than 60, then we're going to do chest compressions at least 100 to 120 a minute. If inadequate respirations and pulse greater than 100, reassess the airway. So there is the resuscitation triangle. So that is separated into basic level and advanced level. Care after delivery. The mother is at risk for serious bleeding, infection, and emboli. Deliver the placenta, control vaginal bleeding, and comfort the mother. After birth, we've talked about a lot of this. So the placenta with the umbilical cord and amniotic sac membranes, tissue linings, and uterus. Tissues lining uterus. Sorry. The placenta delivers. Placenta delivery starts with labor pains. May take longer than 30 minutes. Begin transport in 20 minutes if it has not delivered. Sometimes you may already be transporting. That's okay. If you have the hands to do that, you are capable of making that decision. Place a sanitary napkin over the vaginal opening. Do not place anything inside the vagina. You do not pack it. Have the mother lower her legs and keep them together, but not squeeze them together. Massaging the uterus, that fundal massage again. That will help it contract, which will control the bleeding and encouraging the mother to nurse. Take vital signs frequently. We want to know if that mother's bleeding. We want to know if she's going into shock. Acts of kindness are extremely remembered in laboring mothers. They will remember you. They will remember the nice things you did for them. If that includes wiping their head, great. If that includes just comforting and nice words, nice things that you're saying to them, that is great. Replace any blood-soaked sheets or blankets. So one, that's going to feel good to the mom. That's one of those acts of kindness. Two, it allows you to see if there is more bleeding there. Complications of childbirth. Common complications are the cord around the neck. We talked about that. It's where you try to slip it over. If you can't slip it over, then you have to cut it. A broken amniotic sac. Infants who need encouragement to breathe. We've talked about all those. Breech presentation. So that is the most common abnormal delivery. So that is when you're seeing the butt or legs that are delivering first. The risk of trauma to that baby during birth is very high at that point. Meconium staining will often be a part of this, but just keep those things in mind. Limb presentation. That is when an infant's limb protrudes out of the birth canal. It's commonly a foot when babies are in the breech position. Rapid response is essential. You cannot deliver this baby in the pre-hospital setting unless maybe it's premature, and I have seen that, but you cannot deliver this baby if it is breech outside of the hospital setting of a full-term baby. When umbilical cord is present first, it becomes squeezed between the vaginal walls and the baby's head. Oxygen supply is interrupted, and this is a life-threatening condition to the baby. This is a prolapsed umbilical cord. So when you have that prolapsed umbilical cord, you need to elevate the hips, administer oxygen if necessary, keep the mother warm, keep the baby's head away from the cord. You do not try to push it back in or anything like that. You are going to, if there's any of the cord sticking out, a sterile moist towel dressing over that, and you are going to have to insert a hand to try to keep the pressure off of that cord. And that is how you are going to the hospital. You are going to surgery with that mother. Multiple births. Having appropriate resources can be difficult. So those appropriate resources may be another ambulance. So you're going to clamp or tie the cord of the first baby, assist with the second delivery. Placenta and cord care are the same as a single delivery. Keep babies and mama warm. Premature birth. Think I've harped on keeping that baby warm. Um, keep the airway clear. Provide ventilations and chest compressions. Watch the umbilical cord for bleeding. Avoid contamination. Try to keep everything as clean as possible. Make sure you are calling ahead to the birthing center. They need to know that you are coming in with a premature delivery, whether that be preparing their isolettes, getting airway supplies. They need to know. This is definitely probably whenever you need multiple ambulances on this scene, because you may need some more experienced providers. You may need to have one crew completely taking care of the baby and one crew completely taking care of the mom. Meconium staining. We have discussed all of this. You're going to maintain that open airway. You're going to provide those ventilations and compressions if necessary. You're going to transport as soon as possible. Emergencies in pregnancy: excessive pre-birth bleeding, ectopic pregnancy, seizures, miscarriages, trauma, stillbirths, and cardiac arrest of the pregnant woman. Excessive bleeding. Main sign is usually profuse bleeding. Abdominal pain may or may not be felt. Assess for signs of shock, so getting that ABCs, your airway, breathing, circulation, and your vital signs. Provide high flow oxygen and transport. Place sanitary napkin over it so you can watch your bleeding. Save all tissue that is passed. Ectopic pregnancy. So any woman of childbearing age who is having abdominal pain, that is considered an ectopic pregnancy until proven otherwise. I'm sure that we have all heard that in every EMS class that we have ever taken whenever it comes to pregnancy and women. So be alert for that abdominal pain that can be referred to the shoulder. There may be some vaginal bleeding. They may have a rapid weak pulse. They may have low blood pressure. They may not know that they are pregnant. So they may have that absence of menstrual cycle. Seizures in pregnancy. So they may have had preeclampsia and now things have changed. So existing preeclampsia, elevated blood pressure, excessive weight gain. And in that weight gain, you're looking at the swelling of the face, hands, ankles, feet, altered mental status, headache, and other neurological findings. So miscarriage can be spontaneous or induced. They will have cramping, abdominal pains, bleeding ranging from moderate to severe, noticeable discharge of tissue and blood from the vagina. Trauma in pregnancy. Pregnant women's pulse tend to be 10 to 15 beats per minute faster than non-pregnant women. Blood loss may be 30 to 35% before signs and symptoms appear. Ask the patient if she's had any blows to the abdomen, whether that be a steering wheel, a airbag, anything of that nature, a fall, stillbirths. So if that baby is obviously dead, do not try to resuscitate it. Provide full resuscitation measures for a baby born in pulmonary or cardiac arrest. So if that mother has died and the baby has delivered, then as long as they are not obviously dead, then yes, provide those measures. Be prepared to provide life support. Provide emotional support for the family. Cardiac arrest in pregnancy. So we discussed some of this, but you do still have a chance of saving that unborn child. You begin CPR on the mother immediately. Displace the uterus if she's more than halfway through her pregnancy, so 20 weeks or higher. Position hands 1 to 2 inches higher on the sternum to make up for the shifting of the heart and the organs. Continue CPR until C-section can be performed or you're relieved in the emergency department. We do not perform C-section. You cannot do that. That has to be done in hospital. So gynecological emergencies. Vaginal bleeding, treat as a life threat. Check for associated abdominal pain. Monitor for hypovolemic shock. Trauma to the external genitalia. When sizing up the scene, observe mechanism of injury. During primary assessment, look for signs of severe blood loss and shock. Consider additional internal injuries. If they have external injuries, they may have internal injuries. Sexual assaults. This is often a very hard topic to cover, but treat immediate life threats. Do not disturb potential criminal evidence. Examine only if severe bleeding is present, only if necessary. They may want a female provider. They may be more comfortable with that. If that is something that you can help them out with, please do it. Try to keep them from bathing, going to the restroom, or cleansing the area. You are a fully mandated reporter, so you have to report any cases of sexual assault. So keep that in mind. Those can be very taxing calls for both you and obviously the patient, but everyone involved, because those are not things that we ever want to see happen to anyone. So I hope that everybody learned something from this. If you have any questions, please let me know. I'm here for you. But thank you very much for taking this class. I hope that you all have a good day.